turn off the transcript. So aims of today's session is, we already know what asthma is, because if you didn't, you wouldn't be in the session, but we're going to just revisit very briefly the brilliant basics and what keeps our patients safe. We're going to look at the implications of asthma in adolescents and vice versa, so the impacts of adolescents on asthma very briefly, and just consider the context of the group that we're talking about here. We can introduce MART therapy for children, I keep saying children, young people over 11, and to consider the place of MART in everyday practice, and also by default air therapy, which we'll talk about in a minute. And then hopefully consolidate all of the above with some case discussions. So I've got a couple of case studies that are at the end. Depending on how many questions we have as we go along, we may get to one, we may get to two. If you have to leave, please leave in time for your clinics, and I'm going to send out a feedback email a little bit later on. As I've said, this is the third of about 7 sessions that I'm giving. They're all the same. Please don't attend more than one, because it'll be very boring for you, to try and capture as many people as possible. I got some feedback from one of the sessions before that I use mnemonics and abbreviations a little bit too much. So I've just added a glossary to the beginning of the slides. So just to whiz through them: air, anti-inflammatory reliever; MART is maintenance and relief therapy; SABA, short-acting beta agonist, so your salbutamol, for example; ICS, inhaled corticosteroid; PAP, personalized asthma action plan, which I'll just refer to as an action plan because it's a mouthful; YP, young person, age 11 plus, purposes of this. PMDI is a pressurized metered-dose inhaler, so your bog standard inhaler, like you'd have a Clenil or a Soprobec or a Sanomol. And DPI, dry powder. And I'm sure none of those are going to be new mnemonics for anybody, but there they are. So, oh, thanks, Pfizer. Lovely. Oh, lovely. So Pfizer is one of our wonderful clinical nurse specialists. I'm going to just embarrass her now and just introduce her for Newham. So if you're somebody that works in Newham, I think there's quite a few of you here actually. Pfizer is one of our lovely team members. Ooh.
Hi guys. Sorry, on my camera, something is wrong with it today.
No, that's okay. Just it's really lovely when my when colleagues join, because you always add really fantastic insights. So sorry, Faiza, I put you on the spot. She's here. If there's anything that you want to add, just dip in. I've been really spoiled and had some really fantastic input from my colleagues across the patch. So I cover all of North East London, but this covers also all of North East London. So we've been having our lovely teams dip in as well. So first and foremost, if we're thinking about asthma at any age, and I do interchangeably say children and young people, so I'm going to apologise for that now. There are what I like to call the brilliant basics, that are sometimes called the 5 pillars of asthma care. So these are fundamental at any age, including adults, for good asthma control. Unsurprisingly, number one, understanding asthma. So if you do not understand what asthma is, i.e. inflammation, you are very unlikely to manage it well. Number two, understanding how my medicines work. Specifically in this case, we're thinking about inhaled devices, but just in general, if you don't understand how your medicines work, or even at a basic level, the pathophysiology of what they're doing or why you're taking them, again, you're very unlikely to adhere, you're very unlikely to be well controlled. Number three, good inhaler technique. Now, actually, I should say device technique, to be honest, but I was a bit lax on changing my slides. Again, you can be prescribed the best medicines in the world, but if you're not taking them properly, it's almost pointless. Number four, having an asthma plan, and that involves any kind of asthma plan. So we know that in North East London, at the moment we're using the Asthma and Lung UK ones, so the purple ones, and that is what EMIS kicks out. Shortly, we will be moving to the Pan London asthma plan, which is a very similar traffic light sort of based system, pre-populated, which is nice. And they'll be on EMIS pretty soon on the KEG template, if that's the template you use, excuse me. And there will be one for a younger age group, one for an older age group. And also, as an aside, we've just had those translated into, I think, 15 languages. So they'll be on there as a resource, but as you can imagine, the IT is taking a little while. And number five, last but absolutely not least, knowing when to seek help. So knowing where you are in your plan, i.e. green, amber, red, but also knowing how to seek help, when to seek help, and knowing that you're unwell. It sounds really obvious, but when we look at the asthma deaths nationally, but also in our patch more specifically, a lot of young people, unfortunately, who died just actually weren't aware that they were having an attack, and therefore everything was delayed. So they're the 5 pillars, as I've said, and we're going to touch on those all the way through. But we also have a load of resources in North East London that kind of work to these basics to just make sure everybody's got a really great grounding. We know in our patch, literacy, health literacy, English literacy, it is quite a mixed bag. So it's important to make sure information is accessible. And then the little point at the bottom, I'm going to try and get my pointer out here. As I've said, we know which children are at risk of dying. We know they're almost the unworried, unknown, unwell. They are not the children sat in severe or difficult asthma clinics. They are the children, young people, sort of niggling in the community that either don't know they have asthma or aren't coded, so therefore not call recalled, don't understand asthma, don't adhere to their treatment quite often, or just don't have a good grasp or a good perception of what asthma is. So yeah, that's sort of the fundamental stance that we take in the asthma world, in terms of asthma is not a difficult condition to treat. And I say that as an asthma specialist, it's not. Largely 99.9% of children would be well controlled with really good basic knowledge. And that's not to say you haven't taught them. We just know that sometimes information takes, I think it's 7 times reiterated to sink in. And as I've said, I won't dwell on it too much because I could talk about it all day long. But in our patch, we have a really brilliantly, fascinating population, so many nuances of culture, but we also have some real barriers when it comes to communication, resources, understanding, lots of cultural perceptions of asthma that may not align with ours. And again, I think there's a few people on the call that have worked with me on the inequalities work. So again, really, really important here that everybody has this sort of basic knowledge of asthma as an inflammatory condition. Moving on quite swiftly, and again, I won't dwell on this because again, could talk about the adolescent brain all day because it is a fascinating thing. When we're thinking about young people, so as I've said, secondary school age, 11 plus, whatever you want to call it, it's really helpful when we're thinking about, especially new therapy, but specifically about young people and asthma. It's really helpful to consider where they are in their development. So this is obviously, sorry, a very busy slide, but it's something I've seen in other presentations that's been really helpful to really kind of hone my brain in on where we are at. When we think about the development of the young person, sort of from younger childhood all the way up to adulthood, it's important to think about adolescence as sort of a time that's kind of bang smack in the middle of that spectrum between completely concrete, black and white thinking through to abstract thinking and sort of the ability to rationalize thoughts, understand risk consequence. For example, a neurotypical young person who is kind of on the right hand side of this page, and actually you don't really develop this completely until early adulthood. I think some of the evidence says even 25 years old. So it does sort of straddle the age groups really. That thought of, I know what asthma is because we've educated them, it's inflammation. Okay, so if I'm treating the inflammation, I need to take my preventer. If I don't take my preventer, the consequence will be I may become sick, I'm more at risk. And that takes a while to develop, and it can be quite challenging, even with some parents. Actually, I think we all know we all know adults that perhaps make unwise choices, which they're allowed to do. If we're going back a little bit, if we're thinking about that sort of oh, that's not what I wanted, laser pointer. If we're thinking about that middle ground where they're still developing that ability to think in an abstract way, which is really probably where we're going to be when we're initiating this sort of therapy, we really want to make sure we're planting the seed of this is minimizing risk. This is a really safe way to manage your asthma. If you do not treat the inflammation, for example, you may have an attack. And it's really building those sort of connections between risk and consequences. I've said it sounds really basic. It's obviously not that simple. And for younger children or perhaps your neurodivergent children, young people, they may never kind of get all the way to the right hand side. They might be more of a concrete thinker. They don't put risk and consequence together. The sense of self might be slightly skewed. There's a reason why young children draw potato people, because they see the whole torso as one thing. So just bearing that in mind when we're thinking about young people can be really helpful, because it does help us build that narrative of what we're expecting them to do. And, you know, making sure that we are fostering the idea that we are treating asthma as a long-term condition. It's not a series of unfortunate events. If we do X, you are more likely to stay safe, live a full life, do what you want, essentially. So more specifically with young people and asthma, there's a few, I mean, there's more than that's on the slide, but again, we could talk about this all day. There's a few really key parts, triggers, factors to be considering with this particular age group. So we've talked about brain development already. You know, you've got lots of developmental even changes happening. You know, we've got the development of the prefrontal cortex. We've got lots of really significant changes happening that will, again, in the neurotypical young person, allow them to move along that spectrum of understanding risk. But we've also got a time of life where impulsivity is high. You know, poor understanding of consequence may mean that they act in a more risky way. And also there's this sort of thing that they feel they're indestructible. You know, I haven't taken my inhaler for 2 years and I haven't died yet, therefore it's fine. And that can be really challenging as a clinician. So what can we do? We can educate. And we can try and help them to understand the context of asthma so they can then apply their knowledge to their own life. Support them in self-management, which we'll talk about in a minute, a little bit more specifically, and clarify that this applies to everybody, absolutely everybody, and actually being very blunt about the risk. You know, you actually are at risk. People do die from asthma. We really do need to be careful here. And in terms of development, we've also got hormones. So I don't need to tell anyone here that adolescence is a tricky time for hormones. There's lots of hormonal changes. We've got puberty, we've got various other things. We've got young women who will be, you know, menstruating for the first time. That can be a huge trigger for asthma. And quite embarrassingly, I've had situations in the past, especially when I was sort of quite new to asthma, where I've had these teenage girls come in into tertiary clinic, actually, in a different area, and they were exacerbating every month, and I was really scratching my head thinking, what on earth is going on? We've done everything, home visits, blood's coming out of her ears, bless her, everything we could think of, and then suddenly clocked that it was every 28 days and it was the start of her period. And there is quite a lot of evidence for that, actually. I know some people in the audience are have interest in things like women's health, so it's just something to be aware of when you're looking at sort of it's not really very PC, child rearing age, I suppose, childbearing age. Things like pregnancy can really impact asthma as well. I had pregnancy asthma, embarrassingly, did not realise till 8 months in that I had it, and my midwives didn't have a clue it was a thing. So again, it's not something that's well understood. And of course, for boys, we've got testosterone and we've got the boy hormones as well. It's just something to bear in mind that it can be a time of real stress anyway, but, you know, add asthma in. You know, if you're having asthma for the first time, or previously well-controlled asthma is now flaring, it can be really difficult. I'm going to move on a little bit and think more about your opportunities here. So when we're thinking about the young people that are moving from sort of primary to secondary school, starting to think about, you know, carrying their own inhalers, having their own plans, you know, maybe having a mobile phone for the first time, it's a really great natural transition point to really start thinking about, I don't mean transition in the formal sense, but supportive self-management, you know, life skills, navigating the system. I quite like to start small and quite young. So 11, 12 years old, encourage them to ask you their own questions. And I quite often will say, what questions do you have? Not, do you have any questions? Let's keep pairing up for a minute or so if the child is okay with that. So that they get used to the idea of consulting with you on their own. You know, that might be one for a little bit older, but it can be really helpful. Ask if they understand how to order a repeat prescription, how and where to collect it, how to make an appointment. Because largely for a lot of our children and young people, their parents do it and they actually have no idea. I know we've definitely got a community pharmacist on the call. I don't know how many parents actually bring their kids in when they collect the devices, and actually you might be the only person that sees the child and the device at the same time. And then last but not least, we've got the desire for independence. So anyone that knows any teenagers or works with teenagers, the desire for autonomy and belonging is incredibly powerful, and it can skew the perception of asthma, beliefs in treatment, diagnosis itself, of course, and device choice for sure. There are some quite interesting myths out there about asthma. I wouldn't encourage you to do this, but I did at one point join like a parents' asthma group on Facebook because my son had asthma. I wanted to see the myths. Left it quite swiftly because it was quite frightening. And there's this, I can't think of the word, concept of the invisible audience. Historically, I've kind of thought, oh gosh, I've got this teenager, they've been a bit stroppy in clinic, you know, they're a bit embarrassed about asthma in school, for example, they don't use a spacer. Oh, but in private, they'll do what I want because no one's watching. But no, there is this psychological sort of concept where they have this perception that they're being watched all the time. And it can be a really strong influence on behaviour even when they're on their own. So it's just something to be aware of. So moving on, MART and AIR regimes, what do they mean? So I did put the glossary in, so I've given you a bit of a steep review. Maintenance and reliever therapy is MART, and AIR, which is a bit newer and something that I've certainly really had to get to grips with, is, anti-inflammatory reliever. So MART, one inhaler to rule them all, just one inhaler. We are ditching the preventer and the reliever as separate, and we're giving one. And in adolescents, in 11 plus, the licensed sort of on-label device that we have is Symbicort Turbohaler. So we're not being biased. As it stands, that is what we've got. I'm told there probably will be more coming up, but at the point of today, unless anybody's got any new information, that's what we have. Anti-inflammatory reliever is slightly different. So it's similar in that you have one device, and again, it's a Symbicort Turbohaler for 11 years plus. We don't do a preventer dose. Instead of having a salbutamol or a different reliever device, we are using our Turbohaler, which is a combination therapy, as the reliever. So therefore, when you need a dose of reliever, you're having symptoms, you're also getting a small dose of inhaled steroid. So you're almost self-titrating, and we don't encourage that in young people, but for this, you're almost self-titrating. If you're having lots of symptoms, you're going to be giving yourself lots of inhaled steroid. So just to put this in more of a visual way, because I quite like this way, it's quite a nice visual. MART, we have our Turbohaler in the morning, we have our Turbohaler in the evening, and then up to 6 puffs a day as a reliever dose, and that's 1 puff at a time. Anti-inflammatory reliever therapy, we've just got the up to 6. And, you know, of course, you have children that don't use all 6 or don't use any at all, and that's quite often why we use it. Hopefully that's clear. If you just think about the benefits of MART and AIR, one of the things that can be quite helpful, if you just think about the fact that this may be quite variable. Quite often when we look at risk in young people with asthma, we're totting up salbutamol use versus whatever preventer they're on. With this one, with a Turbohaler, for example, you have a dose counter. We know exactly how many doses somebody should be using or how often they should be using a device if they are adhering to their preventer regime. So there's 120 doses in a Turbohaler. So if you're on 1 puff twice a day and not using any rescue doses, it will last 60 days. If you're on 2 puffs, it will obviously be 30. So if they are needing a device more often than that, or you're noticing that the intervals are getting smaller or they're requesting more, the chances are they're needing more rescue doses, and it's worth getting them in for review. It is a new way of thinking, but I think it will be helpful once we've started to get our heads around this new way of thinking. I know in adults it's not new. We're kind of late to the party in peds. So where does MART fit? Oh, that done quite nicely. So as I've said, it's not a new regime. It's well established in adult care, is my understanding. And I know that my adult colleagues are, you know, it's their bread and butter actually in asthma now. Our national and international, so GINA, for example, guidance has promoted MART therapy for quite some time, but it has a really clear place in the newest joint guidelines. So that's the BTS sign and NICE, heavily anticipated. We've waited for a long time, that came out just before Christmas. As I've said, this is focusing specifically on young people 11 plus, because under that age, MART has its place. It's certainly in the guidelines front and centre, but use is off label, and it's a bit of a different ball game. So when we look at the guidance, hopefully you can see this because my screen shows it. It's absolutely tiny. We've got a very clear but somewhat busy flow chart. So we've got at the top, take into account reasons for uncontrolled asthma, etc., before starting, which we're doing because we're covering the brilliant basics. We're using our KEG template. And we've almost got two paths here. So we've got newly diagnosed, and hopefully you can see this. There's almost two, again, there's two little branches here. So first and foremost, newly diagnosed, and they're already highly symptomatic or they've had severe exacerbations. If they are able to, we go straight to low dose MART if they are, able to use the devices. If they are not highly symptomatic, of course, or haven't had exacerbations, you could actually offer in the first instance just air therapy. So that is just using the device as needed. And that is historically where, before the guidelines changed last time, you might have offered just a salbutamol inhaler because you're not sure. So again, you're keeping them safer because you are offering, basically you're taking away the choice between the preventer and reliever. If they are having symptoms, we're treating it, we're nipping it in the bud with the inflammation. And then, as you can see, it goes down, offer low dose if it's uncontrolled. If it's still uncontrolled, we step up to moderate dose. And then it goes on. We don't need to read the whole slide. Similarly, we've got a flow chart for those who are already at the point of guidelines, because, of course, there are plenty of children with asthma before the new shiny guidelines came out, with an existing diagnosis. So it offers sort of it's almost like a switching guide. If they're on salbutamol only, which no one should be actually these days, we offer air therapy. If it's uncontrolled on low dose ICS or low dose ICS LABA, essentially the lower steps, we consider low dose MART. And again, onwards with the relative things. What we need to remember is that it is a consideration. We are not going to be blanket switching people, and we'll mention this in just a minute. We'll go through it. So hopefully that's helpful. There is a QR code on the slide to the guidelines, but I can always pop them in the chat as well. So what does it mean? If you attended it, I shamelessly stole this slide from my own presentation on the new guidelines. If they've got an existing diagnosis, they're well controlled and they're happy with their treatment, for example, with PMDI and spacer, nothing. We're not going to blanket switch somebody just because the new guidelines says we should try MART. If the patient would like to try MART or would like to try something different or doesn't want a spacer anymore, of course we would be suggesting MART. But with existing diagnoses, if control is suboptimal, we would absolutely consider it in the first instance. And then when we're thinking about our new diagnosis, again, we would be considering it straight away if they're able to use it. And again, we're going to talk about that in just a second, because there are things we need to be checking for any young person with any new therapy. What this doesn't mean, as I've said, this is not the same as your brand switching. It's not the same as switching Clenol to Soprobec, for example. This is a completely different device. This is a breath actuated device. So we're not going to be doing that. We wouldn't be doing that anyway. And we wouldn't be switching to MART without an acceptable assessment of the ability to actually do it, the technique with the device, or understanding of the regime, because it is a new way of thinking. At the bottom here, you can see a little link, and I popped it in the chat before we started. It is there's a switching guide that is provided by the Primary Care Respiratory Society. If you're not a member, it's really fantastic. If you've got a respiratory interest, they've got some really fantastic things and some really great kind of recent articles around, action following the new guidance. When we think about our choices, as I've said, this is not a bias, it's what we have on license for young people. The company actually has a really fantastic, and I'm going to completely admit, I have a complete mental blank on the dosage. For some reason, my brain doesn't retain it. I have this in my diary, tucked in my diary as my little cheat sheet. So as you can see, there are actually 4 options for Symbicort. And when on my screen, I can't actually read the writing because it's small in presenter mode. But essentially, we've got at the top, we've got a 100/6, a 200/6 turbohaler, a 400/12, which we, wouldn't necessarily be using in young people anyway. But if you've got a patient that 1 puff versus 2 puffs is going to make a difference, may be helpful. And then at the bottom, we've got a PMDI, which there is a lot of research going into at the moment, and lots of studies happening around whether younger children can use MART with a PMDI rather than a DPI. Just to note that the dose is different. It's 100/3, so it's not really it's not a direct swap, because I know I've had lots of questions about that. So we've got here maintenance here, but we're kind of ignoring that at the moment because we're thinking more about adolescents. We've got maintenance doses. Oh yeah, I can see the question, Helen. Let me try and explain it in a better way. We've got maintenance doses here. So for adolescents, we've got the Symbicort 100/6, 200/6. When we're thinking about our maintenance dose, it's 1 to 2 inhalers, 1 to 2 puffs, sorry, twice a day. You can see on the MART regime, it's a bit confusing, this page. This is why I save it in my diary. That's for maintenance. So that's for somebody that's only using it as a preventer. We've then got MARTs. So we've got our inhalations per day. So for example, for moderate asthma, we would have a puff in the morning, a puff in the evening, plus up to 6 extra reliever puffs, if you like, in one day. And the guidance says, I don't know if you can read it, because like I say, my screen on this one is a little bit fuzzy. If you're using more than 8 inhalations daily, we should really be making sure our patients are seeking medical advice. And the absolute maximum is 12. So in the event of an attack, you can take more, but we would obviously be saying absolutely seek emergency advice. And the dosages are the same for both. In terms of your reliever doses, it's 6 for both. I'll send you I'll pop the link to the resource in the chat because it is really helpful. And as I've said, I have this printed out and I have this in my diary because I sometimes have to check which is which. When we're looking at just reliever therapy, so air therapy, it is the 200/6 that we would be using because, as you can see, it's 1 inhalation as needed in response to symptoms. Again, no more than 8 daily for that because you've not got your preventer doses, and the absolute max is 12. This is a little table that shows the ICS equivalents, which is quite helpful, I think. There's been various iterations of this with the different guidance. So this is just Symbicort, and we can talk about just Symbicort in this because that's the licensed inhaler for young people. That said, though, where I'm not familiar with the others because obviously we don't use them in young people, but if they sit in this table, you could obviously apply that. So for example, you've got here a dry powder inhaler, 200 to 400 micrograms per day. So i.e. 1 or 2 puffs of a Symbicort, 200, for example, 100, sorry, would be equivalent of a Soprobec 100, 2 puffs BD, and it kind of all applies. I don't think you can see this one. And then down here we've also got the equivalent dose of Seretide 125, for example, or I think the generic name is Combisar, maybe. I can never remember that one. 2 puffs BD. So it's really helpful. I popped the resource that this came from in the chat at the top as well. It's the PCRS one. And again, there's a really lovely switching guide for adults and young people, so hopefully it will be helpful. Again, in the same resource that is up here, up the top. Put it in here. So, excuse me, let me find the page. Yeah, there we go. It's on the chat. When we're thinking about initiating MART, there are some fundamental things that we want to be doing to make sure someone's using it safely. So what I like to use the mnemonic air. So we've got our, oh my goodness, asthma plan. We've got our device technique, inhaler technique, and we've got review. So we've got here our device technique. So I've got the company will send you, if you ask them, and I can certainly provide details, some training devices. So we've got a placebo turbohaler here. Gosh, it's stuck. See-through, which is really nice. So wherever you work, you can request those. What's quite nice is hopefully you can see that the young people can see how it works, and you can see the dose counter as well. I think you can see that it goes red. There's also training whistles. So first and foremost, the device technique, we take the cover off by unscrewing. We check the mouthpiece is clear, and we check the dose counter. So again, this is obviously see-through, but for the real one, you would just be able to see the dial. I don't think you can actually see that because it's see-through. It becomes red when there's about 20 doses left. So if anyone's ever worked in retail, it's a bit like your till roll going red. It's a really helpful visual. And we have young people in the past who have died because they're puffing on empty inhalers. So it's really important to know. Anyway, what we say is we hold it upright because it scrapes off a dose a bit like a Pritt stick. We twist the base until it clicks and we twist it back. We blow out away from the device. We get a good seal and we breathe in hard and fast. And we get the young person to hold their breath for a few seconds or for as long as comfortable. And generally these are one puff at a time. So that's you done. There are some training devices that are really good. They're called training whistles. They're single patient use, and they'll make a sound if you have an optimal inspiration. So it's quite loud. Like to remind them that they won't make that noise for real life because that would be really embarrassing. The video underneath I've also popped in the chat at the top because I think a lot of you will be familiar with most of you I'm sure will be familiar with the device and how to do it, but it's just coaching that young person and using it well. If your practice has an in-check device, you can use that as well, but there's nothing like using a real one to demonstrate. Moving on a little bit, as I've said, the next fundamental step for starting MART is having an action plan. This is the one that Symbicort provide, and we will have a Pan-London MART and AIR plan in the near future. It's just not ready yet, apparently. So it's very similar to our asthma and lung in that it's traffic light. So green, even when I'm well, I take my preventer. For the purposes of this, it's a 100/6. I take one in the morning and one in the evening. And as I've said, there are dosage regimes that would go up to 2 or change to a 200/6. If they're amber, we've got niggling symptoms, we're maybe needing our to use a rescue inhalation, a one puff at a time. We've got up to 6, as I've said, of those in the day. And you can add in, specific advice around what to do in that category. So largely that would be sort of see your primary care clinician, see your asthma team. If you're somebody that does peak flow, maybe do some peak flow readings. And then red, as always, red is you're having an asthma attack. As I've said, you can use 6 puffs a day. You could use 6 puffs of this device. And we actually had a really interesting question in the last session where somebody said, what if you've maxed out your 6 as a patient and you're still in trouble? So we'd be saying, of course, if it's an emergency, you've called an ambulance, let's just play devil's advocate. You've used your 6 puffs in the last few hours, let's just say, you're not getting better. You've called an ambulance. The ambulance says they're going to be a bit too long. That's an emergency. If they need more puffs, you could have another 6 actually before you max out. It's an emergency as long as they're seeking help. You can use those. And we had, as I said, a really lively discussion yesterday around it. And one of our consultants actually shared sort of her view, which is that, if it's an emergency and you're really concerned, you think they're going to, they're at risk of a severe or fatal attack, keep using them if you need to, but we must make sure they seek help. Call 999. Do not put the young person in the car. Help will come to you. We've had too many children in sort of fairly recent history that have exacerbated, at home. Parents have put them in the car, and they've had an attack on the pavement and become very unwell. When we're thinking about our patient profile, so particularly your high-risk patients, MART therapy is, as I've said, it's a really great therapy for everybody, but it's particularly effective for patients who overuse salbutamol. So whether that's appropriately or not, I'm sure you've all had patients in the past where they are sort of emotionally attached to their blue inhaler. It's a bit of a comfort blanket. At best, they're using it too much inappropriately. They don't need it, but they're using it. And at worst, they are genuinely symptomatic and really struggling. Either way, MART is a good call. And historically, I don't know if anyone else in the room has done this, but historically in sort of the asthma world, we've actually, before it was so mainstream, we've actually used it largely for patients who perhaps were in that group. Actually, we're quite concerned they're using too much salbutamol. They don't really need to. We're not going to let them vote with their feet anymore. We're putting the blue inhaler in the bin and we're moving on to MART so that they cannot choose. They have to take the preventer. And that's kind of point 2, really. They can't vote with their feet. They help on device. If they have symptoms, they have to take a preventer alongside. And it is, I will openly say to a young person, we are quite sneaky. I am being a little bit jammy. I'm not going to let you vote for just the blue inhaler. We need to make sure you're safe. Another group of young people where this is really effective and particularly good is young people who don't use a PMDI and spacer or don't use their PMDI optimally. if they can demonstrate a good inspiratory drive and use the device, they will achieve good lung deposition. And quite often we have these chats with our young people where we say, what are you using? You're using for example, an inhaler and spacer. They're not using a spacer, essentially. We are nagging them all day long. We are constantly bugging them to use a spacer. Actually, you've actually got a choice. You can use, excuse the stickers, because hopefully they wouldn't have that. You've got a spacer or you've got this. That's your choice. And a lot of the time, actually, that's enough of a sell. It can feel a bit like a sales pitch. You can use your PMDI, but I expect you to do this. I expect you to take it properly. And then the last one is the young people who struggle to form routines or don't really notice when the medication is running low or empty. So a lot of our young people who, have a very chaotic lifestyle, or family who have a very chaotic lifestyle, lots of stress, lots going on, busy households, overcrowded households. But also some of our patients who do struggle to, as I've said, form routines, are children with ADHD, for example, or parents with ADHD can really struggle to do that. They're sort of forced to self-titrate. So that's really helpful. And then, as I've said, in terms of knowing when your medication is running low, having a dose counter is so helpful. They need to know where to look for it, but it's pretty obvious. Really helpful. Introducing MART. So I've already said one of these already. Top tips. Introduce it as one option. You can use this, which you're already prescribed, but I expect you to use it effectively. I expect you to use a spacer at home and at school. Or you can have this one, which doesn't need one. One of our CNSs in the first session actually pointed out that her best sell is that it fits in a blazer pocket. Also fits nicely in a rugby or football short pocket. Works just as well as a SAVA if you're symptomatic. Which a lot of our young people don't realise. And as I've said, it's one device, it's treating inflammation whilst treating symptoms, and we have a dose counter. So again, sometimes it isn't much of a sell, sometimes it is a little bit more. Something else that I quite like to say to families and young people, where we are thinking, gosh, it is going to be a bit of a sell here, switching from the salbutamol, which usually is the one they're using more, to a turbohaler, is actually you're overusing your salbutamol so much, you're downregulating your receptors. Therefore, if and when you become very sick and have an attack, it might not work anymore. This is why we're changing things. We're being very blunt about it. And again, largely in my experience, in various places, it has been something that's worked well. It is a really good treatment, and it is very effective. Again, when I spend time sort of anywhere, but largely in primary care with high-risk patients, one of the assumptions that a lot of us make, and myself included in the past, is that for young people, they're just not going to understand the concept of prevention alongside symptom management in one device. And I sort of challenge that, because if we're giving them good information, which I know we are, and we are explaining what asthma is, and we're explaining what inflammation is, and we're giving them information that is meaningful to them, they can understand that. Young people can understand the concept of prevention over time. And something that I popped up on my on clearly a very early morning social media scroll a little while ago was something that I think was targeted at young people, judging by the advert. And it struck me as a really interesting concept that this skincare brand, which I'm not familiar with, but this skincare brand, its biggest sell is that it handles like symptoms. So as in skincare symptoms, spots, dryness, whatever, unpleasant for the young person symptoms over time by sort of covering it up. And this whole advert was this influencer saying, handle symptoms over time. You're doing prevention while you're looking good. And it really struck me that actually that is we are doing them a disservice by assuming they don't understand. Just incidentally, this skincare product is bright green. So when they put it on, it's bright green. So again, if they can understand that, they can absolutely understand the concept of MART. Do we still prescribe salbutamol for children, people with lots of symptoms despite using MART? So the short answer is no. We prescribe MART on its own because that is now their reliever. There are some young people where we perhaps still prescribe a salbutamol but they're kind of the exception to the rule, really. So we had this chat in the last webinar that I did. If you have a young person who has anaphylaxis and salbutamol is in their anaphylaxis kit, we would be wanting to prescribe them that. It's almost a one-off though, because it's to make sure they have it in the kit. Because if that patient, I know this is very nuanced, but if that patient has a sudden anaphylaxis, they may not be able to use one of these. But generally speaking, yes, we would say no salbutamol anymore. We use MART, and it does work. If they use it well, they use it properly, it does work. I did a presentation a little while ago, gosh, a couple of years ago now, where Asthma and Lung UK were in attendance, and I had this question came up, and they were very firm in saying, no, you need to trust the science. You need to trust the science that they are self-titrating. And patients who use MART effectively, they don't really have attacks. It does work. And I know it's a really tricky change, isn't it? A lot of us do sort of sit on our hands and think, oh gosh, I need to stop thinking about the blue inhaler. In summary, we've got pros on the left, we've got cons on the right. I think we've gone through these already. The one device is no choice. Effective low risk regime. It really is low risk. It's really risk averse actually. Once established, we've got limited options, as I've said. Dose counter is a winner. I haven't even touched on the carbon footprint because we don't really have enough time, but a DPI is much lower carbon than a PMDI. And actually, if you look at the bigger picture, having well-controlled asthma is the best thing that our patients can do for the environment, because they're not adding lots and lots of carbon. And cons, as I've said, that we've talked about them already. It can be a tricky sell. Some require more support, and adherence can still be an issue, but it's less likely because you're taking away the SABA. Trials for diagnostic uncertainty. Could we be overusing steroids? I guess if you're uncertain, you could do a trial of treatment, so a monitor trial of treatment. So I've just seen a question in the chat from Tonya. I guess unless they become sort of emotionally attached to this device or overuse it really inappropriately, if we're thinking that a patient is well controlled enough to not need a preventer, we could step them down to air therapy, and that happens quite a lot as sort of a middle ground between, asthma, well-controlled asthma, and de-diagnosis. And then in the other way round, you could start them on air therapy as per the guidance, and then step up. What's the time? Let's have a look. Summary again. We've been through this already. MART should be considered as first line for young people who are able to understand the premise, understand the plan, and use the device. Young people require very consistent but also quite careful management and assessment when it comes to changing their regime, and certainly initiating MART in the first instance. Informed patient choice is key, and we need to really understand where our patients are at with their understanding. And if the patient's happy with the NDI and spacer and is adhering, optimal technique, they're doing really well, they don't have to switch. We're going to move on to some case studies. If you do need to leave, don't worry. I appreciate that a lot of you have afternoon clinics, but we will whiz through these. So case study 1. And these are both based on real patients, anonymously. So this is a 12-year-old boy seen in the GP practice for a post-attack review. His prescription is there. You can see that he has got a preventer prescribed, as well as a reliever. He's got an aero chamber with a face mask. So I just read that with his age in mind. As you can see, he has got quite an interesting, pattern of uptake. So his Salamol, his reliever, he's had 8 dispensed in 12 months. And for his preventer, he's only had 3. And we're going to talk about that in just a second. History is as per below. So he's quite atopic, quite an atopic history as a smaller child as well. Coded as viral induced wheeze since age 4, and then asthma. He was actually on Plenol before, that was stepped up from 1 to 2 parts last year, and then the brand was changed to Silprobex. So they've had their device changed a couple of times. They're also a quite anxious young person. They were referred to CAMS, unfortunately rejected, as we often see, because they didn't meet threshold, and therefore signposted to Cooth, which is a really great resource, actually, if you're not familiar. So just bear that in mind. So on arrival, when they come into your room, they appear well. It's 3 days post-attack. they're not wheezy, but they have taken a reliever a few hours before. You start talking about preventive therapy, sort of what caused the attack. You know, are you actually adhering to any of your treatments that are prescribed that could have kept you well? They're taking it sporadically, usually just in response to symptoms, but not regularly enough to be therapeutic. So you may well know this already. It takes sort of 4 to 6 weeks for an inhaled steroid to start working. And quite often what we see is they'll get quite good after an attack, or, you know, during some of the trickier times of year for that patient. They'll feel better and then they stop taking it. And then obviously the cycle starts again because the inflammation returns. They report using a spacer sometimes, but this is a yellow mask air chamber. And quite often when they say sometimes, it's almost all of thirds. You sort of assume that's probably no or rarely. They're using the rescue inhaler frequently, as evidenced by the fact that they've had 8 even in the last 12 months. They do have very clear triggers, i.e. high pollen, high air pollution, weather changes, they can be really significant factors. If we're coughing when we're laughing, that is a real red flag. It's really indicative of really severe inflammation, so that's just something to bear in mind. But also, quite often takes their blue inhaler at the school gate, which we see quite a lot with our anxious children. There's very clear timestamps when they take it inappropriately. It's the control test here. Hopefully you can see this. It was a screenshot from the real one. So they scored 14 out of 25 when they self-reported in the clinic room. So they've answered some of the time here. As you go on, you know, you can see their answers. Taking it sort of 1 to 2, I think that's 1 to 2 times a week. I actually can't read because my screen is tiny in presenter mode. I would actually argue that if they judged question 5 sort of a bit more realistically, they are quite poorly controlled, so it probably is actually a little bit lower. 14 out of 25 is very poor. We'd be very concerned at this point. So what else do we need to know about this young person? Has anybody got any thoughts, or should we just kind of plow on? I know we're quite short on time. Just turn off the clicker. So we need to know whether they're having symptoms or feelings. It sounds like they're having both. We need to help them unpick which is which. So that could be a peak flow, and peak flow is a really fantastic tool for that picture of anxiety versus symptoms. If you think about the symptoms of anxiety, some of them do overlap with asthma. It can get quite difficult, and it is a long game. It's not going to be something they fix quickly. And actually, the device they've got, can they use it? Will they use it? The spacer, I would say, is inappropriate. They're 12. They shouldn't be having a yellow mask. There are other options that would optimize therapy. What would MART add? So what they're doing, by the looks of it, is they are, and actually the real patient was doing this, they are voting with their feet. They are choosing to use the salbutamol and to ignore the preventer. So if MART was something that they could do in terms of the device and understand, MART would remove the ability to do that. They would have to be treating the inflammation as well as treating symptoms. And I guess I think as Tonya sort of said, with a worry about overusing, sort of if they are using their salbutamol appropriately with the 7 in a year, which is high risk, if they use lots of extra doses of MART and they are having symptoms, they're treating the inflammation, they're titrating their own behavior to their symptoms. If they are using it inappropriately and they use this device inappropriately, there is a risk they'll be receiving more steroids, but actually it's more than they were receiving before, and they were quite poorly controlled. So it is a fine line. Personally, and in fact, that's what happened with this patient. We did put them onto MART. They actually really liked the device. They didn't use the spacer. They didn't want to use the spacer, and it was a really good move for them. There was just a lot of sort of careful consideration of making sure they actually understood the concept. Case study 2 is a different one. So again, based on a real patient, we've got a 15-year-old young person who attends for annual review, wasn't brought to the last one. Historically has been quite poorly controlled, but has been pretty good for the last couple of years. Medication uptake is on the screen. So we've had 5 stop Prevec devices in the last year, but actually in the last 6 months, they've had none. So they were all sort of 6 months ago, if you like. Requested 2 Selamol PMDIs in the last 12 months and 2 mouthpiece spacers. One was for school, one was for the football bag. They're not really using either. It's sort of in the bottom of the bag. Despite having excellent technique when coached. because they just feel it's not convenient. They rarely need the salbutamol. Can't remember the last time they used it, and that's sort of evidenced by the fact they've only had 2 PMDIs in 12 months, and actually they're both pretty much full. They're really active. When you last reviewed them, because they missed the review last year, they weren't so active. So they're actually playing quite high level football now, twice per week, plus running in PE. So I think we've all had patients like this where they are just super duper active. This is her asthma control test score. I think this was also a screenshot actually, from the real deal. Our asthma control is 21 out of 25, which is fantastic. And again, I would argue, you know, and this is why this is a tool for discussion, not necessarily to be taken absolutely as a concrete thing. She was quite conscientious and said, "Oh gosh, I'm going to choose once or twice per week," because she was occasionally what she called short of breath, but actually sounded more like she was really cardiovascularly working really hard and a bit puffed out during sport. Not really having you know, symptoms at all. And then she'd sort of said she'd not gone for not at all with the question about salbutamol. She'd gone for the one before because she couldn't remember. And I don't know about you, but if a patient can't remember when they last used their salbutamol, that's always a good sign to me. They can't remember. It means they're rarely, if not ever, using it. And again, similarly to the last patient, I think we said, actually, you're really well controlled. I wouldn't say you're somewhat. Again, she was just being a little bit self-deprecating there. So it would probably be more like 22, 23 out of 25. Similarly to the last one, what do we need to know? We need to know any other symptoms that she might be having that suggest an alternate diagnosis or any other issues. But actually, this real patient for real life was basically symptom-free. And actually, it might be that she doesn't have asthma anymore, and de-diagnosis might be on the cards. In this situation, actually, we had a really long discussion, and we had an interesting one yesterday with this patient. What would MART add? Well, MART would add a safety net. But actually, if they're not having subtle symptoms, they're not using rescue inhalers at all. What we actually did with the real patient was we really carefully considered both options. We actually ended up putting them on air therapy. So we went round in circles in the clinical discussion, and we said, you know, actually, at worst, they're gonna, you know, at worst they're on the air even if we put them on MART, because she's not taking her preventer. The dose counter will tell her if she needs to get a new device, which isn't really a worry because she's not using it at all. We actually don't know if she needs a preventer at all. She's not reporting any symptoms, so we put her on air basically as a safety net, just in case they recurred. It was a really interesting one, and this patient, the real patient, really made me eat my words, because I'd said to the pharmacist I sat with in primary care, oh gosh, I'm really not, you know, I'm a bit cynical about air. I think, you know, we quite often prescribe MART, and actually what they're going to end up doing is air. I feel like we should be really setting the bar a bit higher. This patient, as I've said, made me eat my words, because they didn't need a preventer, and we could have argued all day long about it, but actually air would have given us that safety net. So again, just another sort of almost the opposite issue really to consider. I'm going to just whiz through some resources in a minute, but there is a feedback survey. It's really quick. If you're able to do it, please do. I will try and copy. I'll see if I can copy the link. I'm not sure I can, and put it in the chat. Or QR code and do it on your phone. It's quite quick. It does inform the next session, so please let me know. And then just some resources, which I've already popped in the chat above. I think we've got some local resources, so your local team, of course. If you don't know who your local team is, pop me an email and I'll put you in touch. We have as I said, CNS in every borough. We have a Pan North East London patient information booklet available. So yeah, MART, we can use MART now for under 11. Sorry, I see. I read your question wrong, Sally. Sorry. So the guidelines say you can use MART in under 11s, but it's off-label. So it is something to be quite careful about. Generally speaking, it's not something people are doing a lot outside of specialist care. There is quite a lot of work happening around use of MART in under 11s. I mean, I would be quite careful about prescribing an inhaler like this for an under 11 anyway. but yeah, it's there, and it's certainly worth a read of the guidelines. And there's going to be some research happening locally around that actually. So we'll be sending out some comms when that's ready. For the intents and purposes of this, we're really encouraging everyone to use MART in over 11s first and getting confident before we start considering under. Hopefully that answers your question. Can you do your eosinophil check and series peak flow diary for diagnosis while using air therapy? I mean, you could do a peak flow diary and series at any point. So yes, absolutely. An eosinophil check, I guess, yeah, you could. That's in the guidelines now. We know we don't have Veno or Spiro anywhere at the moment in North East London for children or young people. So yeah, you could. I mean, have to be, if you're thinking about a trial of treatment as an objective test, you'd want to have it as a proper preventer. So you'd want to be doing MART rather than air. But you could absolutely ask your patient if they're doing a peak flow diary, for example, over a few weeks, ask them to mark pre and post if they're using a dose of reliever. I think if you're using air therapy, it probably wouldn't, but I will double check that. But I guess the eosinophil count's going to might just be high in some children anyway, very topic. So to be honest, I think a peak flow diary would probably be more useful in that situation. What was I saying? Oh, multilingual resources. So we've got resources. In your KEG template, there's a link out to the Pan London. There will be a Pan London PAP and MART PAP shortly. We also have booklets in about 15 languages, I think, at this point. And we've also got some educational animations for children and families. I've just managed to get the subtitled version. So if you would like the videos, it's a 5-minute video on the five pillars of asthma care aimed at children and young people. I've got it subtitled now, so it can go on waiting room screens if you don't have sound. And again, I'll pop it in the chat. Tier training, if you haven't done it already, I'm sure a lot of you will have done already. Think about where you fit. Thanks, Tonya. Think about where you fit. Clinical minimum is tier 2, which is free in around 45-50 minutes. 3, if you're a prescriber, you should really be doing tier 3. It's about 7 hours. You can save and come back to it, also free. I'm going to put the feedback thing back on just in case. Sorry, it's been a little bit whizzy. If anyone's got any other questions, do feel free to email me. I'm laura.king4. I'll put it in the chat, actually. I can't type and talk at the same time. And yeah, if anybody wants any advice or signposting, like I said, just pop me an email. I'm in post till the 31st of March. But after that, can still signpost you. Yeah, feedback, honest feedback, very welcome. I'm just going to stop recording. Stop recording.